So thank you for the opportunity to present to you on this topic. I want to give you a quick sense of a program we have up here in Ontario, Canada, on mentoring family physicians around mental health needs of their patients. I work with quite a large group on this. The particular co-authors are Jose Silveira, Pat Rockman, and Arun. Pat and Arun are family doctors. Jose is another psychiatrist. And as I say, we're optimizing collaboration and specificity. That gives you a sense of how much collaboration occurs. First question is, why was the network created? And there's quite a lot of data to support the idea that family doctors generate a lot of questions when they see patients. The questions tend to be about complex issues, interactions between different types of comorbidities, and are actually quite hard to solve via literature searches and that kind of research-based solution. What they find fits best in their practice, typically, is speaking to a colleague, the kind of hallway conversation that as physicians we're all familiar with. But because they don't necessarily have a psychiatrist in their hallway, they often don't get a chance to ask this kind of question. So we wanted to try to make a mental health specialist available to family doctors in a way that was that straightforward. There's a problem with doing that in Ontario, the province where I work, because it's very large and psychiatrists are maldistributed. This map gives you a sense of what Ontario looks like. Just to give you a sense of scale, there are the Great Lakes there, those light blue shaped lakes at the bottom of the circle. The area of Ontario from the top of Lake Superior, the most northern of those lakes, to the bottom of Hudson's Bay, that space is larger than France. So this is a huge geographic mass, and the population is distributed densely in some parts and much less densely in others. When you look at the actual ratios, it doesn't look bad. A psychiatrist for 6 family practitioners. But the next graph, which is a series of bar graphs, shows you that the distribution of psychiatrists per capita in Ontario is very maldistributed. Around this big city, we have a lot of psychiatrists, and it tails off very rapidly, so that much of the population really does not have access to the psychiatric profession. So we did a needs assessment when we started this and asked physicians what their requirements were in terms of specialist support, and they were quite clear. They wanted help on basic clinical management issues. They wanted to know how to treat difficult diagnoses. They wanted to know how to administer treatment, particularly pharmacotherapy that they felt was outside their scope, and they particularly wanted a chance to be able to speak with somebody reiteratively about the patients they see. And they were happy to do it via email, telephone, or face-to-face. So we set up the network with the objective of providing point-of-care learning. We wanted collaboration at a distance to enhance the quality of mental health delivery, and we hope that what we could do is help the family doctor in their office take care of mental health care patients faster, better, and more efficiently, and in fact at reduced cost. So let me tell you, that was some 10 or 15 years ago now. At the current time, we have about 450 family doctors in the province engaged with this. We have 46 mentors. The mentors consist of psychiatrists and family doctors who only do mental health care work. They are known locally as GP psychotherapists. And we set it up so there are 2 mentors, typically a psychiatrist and a GP psychotherapist, with a group of family doctors, anywhere from 8 to 20, in a small group. And that is organized by and large geographically. We've tried to organize it by topic of interest or practice type, but the family docs are vocal about their wish to be connected with a specialist who's close by them. The family doc initiates the contact. They call up a mentor. They say, I got this issue, or they email a mentor, or they fax a mentor. They say, I have this issue. They don't give us patient identification, but they give us a sense of what the problem is. And we reply within 24, at longest 48 hours, with our advice about the case. In addition to that, we have one annual big continuing medical education conference each year. And we have, depending on the group, small group meetings or conference calls. So in my group, for instance, we have a monthly conference call for 90 minutes, and anywhere between 3 and 10 family docs would log on with me, and we would discuss whatever case or issue they wanted to discuss. Okay, this is now getting into the outcomes to see how we've done. The first thing we did was check with the mentees, get their feedback about how we're doing. And this gives you a sense of what that feedback has been like. So first of all, people have found that their access to psychiatrists has been much better. They used to have a difficult time getting psychiatrist input. They have much less difficulty now. Same goes with access to a psychotherapist who might not be a psychiatrist. The degree of difficulty with reaching somebody has gone down. What about their satisfaction with the actual contact itself with psychiatry? That's gone on up markedly. So about a doubling of satisfaction with contact with psychiatrists or with GP psychotherapists. So we are making it less difficult for people to get mental health care input, and we're increasing their satisfaction. When we ask what the kind of thing is that help has occurred with, they identify the stuff on the slide. So they feel they've improved their knowledge base. They certainly feel better connected to us. They feel their patient care has improved. They feel that they've reduced the time to optimal treatment. And although this is not a patient measure, this is a family doctor's judgment about the patient's symptoms, the family doctors report that they think we've improved symptoms in the patients that they've consulted on in over 60% of cases. So we were interested in getting a little bit more detail about this, and to do that, we did a grounded theory analysis of emails that have been used in the network, because the email use had gone up from 20% of mentees to 40% of mentees. It would probably be 80% at the current time. And we looked at emails and, as I said, did a grounded theory analysis to look at what the emergent themes were. What we found out was that mentees demonstrate concern and need. They're grateful, self-effacing almost to a fault, apologetic for having the need for help. Mentors transfer knowledge both directly, here's what I would do with this case, and indirectly, here's a presentation, here's a link that you might find helpful. They promote generalization of their expertise, they encourage, they support, and they tend to try to diminish the hierarchy between the specialist and the generalist, typically by using things like humor. Our understanding of that process was that it generalizes to other patient care and collegial relationships. So the mentees in the program tend to be better not just with the patient they've consulted on, but with other patients of that type. And they tend to feel more comfortable about accessing other specialists. It requires relatively few resources. And although we haven't done a frank analysis, certainly it has a face validity that it saves costs. For instance, that 90-minute phone call that I do once a month costs the Ontario College of Family Physicians about $150. That would be one contact with one patient for one consult billed to the healthcare plan. And we cover discussions of many patients in that time. So the mentee drives the process. Questions are targeted to the immediate clinical need that the mentee has. Their knowledge and skills develop over time because they get ongoing input from the mentor. It's a friendly, respectful, nice collegial communication. The responses start off quick and brief, practical, specific. And the outcome of patient care is actually shared between the two physicians. which we feel is an important part of this having ongoing relevance for both parties. One family doctor referred to it as decision support for decision fatigue. They can get worn out doing a lot of these clinical decisions over the course of the day, and it's very helpful to be able to access a specialist to help them out. So we would summarize this as the learning relationship, that educational transfer is contextualized in a trusting relationship, and that we provide point-of-care teaching via mentoring. And that is, in fact, the optimal strategy when you're dealing with an experienced clinician who manages many, many things very straightforwardly. They don't really need a refresher course on how you prescribe an antidepressant. They really need to know how you prescribe an antidepressant in somebody who has an ongoing PTSD and substance use and has just delivered a baby. That's the kind of issue that we get invoked in, and those are hard answers to find in courses or literature. So we believe the dialogue increases clarity and applicability, that clinical complexity is addressed within the context of that, and that the whole consistency and longitudinality of the trusted relationship is what makes it highly valued. In fact, we end up with really a kind of community of practice that is quite geographically distributed, but in a collegial way bound together. So that's the piece on the network. When I originally presented this, they asked me to speak also about other applications of technology in the work we do. And the one I would just mention briefly is that we are developing an app for smartphones looking at the experience of being a psychiatrist on call. The problem is, of course, that when you're on call, the issues are of high intensity, but they're low frequency. You don't see them often in your ongoing day-to-day practice. So they generate high anxiety. When we looked at our colleagues and asked them for what situations were like that, they talked about these four things: delirium in a medical surgical ward, aggression in the emergency room, medical illness on the inpatient psychiatric ward, and some medical legal situations. So we have developed a steering group that consists of doctors with different expertise and setting under the continuing professional development banner of our Department of Psychiatry. We've pulled together guidelines from a number of sources, and we're blending those together to develop the app, which is based on clinical presentations. So when you open the app, you'll have a choice of pursuing information about the agitated patient or the sick patient, or the violent patient, that kind of thing. And our colleagues in Singapore, Drs. Zhang and Ho, are doing the actual tech development. And that's the link to the first iteration we have. But we're moving that forward as we talk. So that's the presentation. I hope that's of utility to you. And I would be happy if anybody has further questions about it. If they wish to contact me, they can certainly feel free to email me. And we can discuss other applications or generalizations. We welcome that level of collaboration. Thank you for your attention.